There are various types of testing that you can do: hair, blood, and urine. I get asked all the time about hair testing, not necessarily for drugs. And we know about blood forensically and pathology. You can test the blood. But certainly the gold standard is urine. That's what we're testing in the office. And certainly when we're testing for opioids or benzodiazepines, that's the gold standard. Why has that become the gold standard, Howard?
Well, first of all, let me talk and make a statement about hair testing. It's not ready for prime time in a clinical practice. Game, set, match. Don't have to say anything more about it. Urine may be the best biological specimen for determining the absence or presence of certain drugs and their metabolites. Urine has an increased window of detection compared to blood, typically 1 to 3 days for most drugs and their metabolite, a little bit longer if the drug is lipophilic, and it's certainly less costly than other testing such as hair or blood, and it's non-invasive. So as we sit here now, we know the most information about urine drug testing, and I think urine testing is the gold standard in a clinical practice for chronic pain management.
Many of us know about the urine drug test that you do in the office where you get a little cup or there's a little dipstick there, and that has a value, but then we send it away for a laboratory test at times too. And what is the difference, Michael, in those two, and why would we use one over the other?
Well, Bill, these are two complementary but very different methods for doing urine drug toxicology tests. The cups, as you say, the point of care testing, are rapid. They give you a quick result. It's usually not very sensitive or specific. It tells you whether something's there or it's not, and it's inexpensive. In contrast, the lab-based tests, or the tests that you send away, are a different method of testing. Mass spectrometry, gas chromatography tests, which can identify specific drugs, opioids and their metabolites, can be a key to identifying a particular agent that you're prescribing, making a distinction from other similar agents in that class that the patient might be taking from other sources, and therefore gives you a more informed result. It helps you to clarify what it is that is actually happening with the patient, and then informs that conversation with the patient to the next level of being able to communicate with them about really what are they doing and why. The other element to this testing is that there is generally a toxicologist who you can contact to go over the results of testing if you find that the result is unexpected in some way, and help you determine whether it's a true positive, a false positive, a true negative, a false negative.
You know, it's kind of like the urine drug tests that we do for pregnancy. Women will check themselves at home getting an over-the-counter product, and they come in and say, I think I'm pregnant, whatever reason, but we always test it again because our testing in the lab is so much better than what you get over the counter, although they're getting better and better. So there are some deficiencies in this, Houman. What are the difficulties with the point-of-care testing?
Clearly, point-of-care testing has many disadvantages and deficiencies, and by now you might get the hint that I'm not very fond of point-of-care testing, especially in a clinical setting where you are treating patients chronically. It might have some role in emergencies, but in a clinical setting where in a long-term relationship, I am not sure point-of-care testing has relevancy for many reasons, and I can pinpoint a few of them. Some of the things that we usually find out that we are all concerned about the cutoff or the limitation. The point-of-care testing has much higher cutoff than the lab testing. So basically, a patient could be taking the medication, so has a false negative or false positive. Could be taking the medication, doesn't show up, or could not be taking the medication, and then you could have false positive.
I just want to make sure that people know what the cutoff means. So that a cutoff means that if it's below a certain amount, let's say 300, and their level is 299, that would show as a negative. And some fast metabolizers, some patients that may have an interval between when they took their drug could be below that level, but be appropriately taking the drug. So a cutoff level, which you're not going to see in a lab test, you will see in a point-of-care test. Do I have this right?
That is correct, and this is why the lab testing is much more precise than the point-of-care testing. Another issue that brings up that whenever you get the point-of-care testing in a clinical setting on a long-term relationship, you have to have interpretation, and your interpretation have to have actions. So basically now, what you have built a data that you have to act on. The problem is with the data is an insufficient data that force you to make a clinical judgment can alter the patient treatment further down the road. And that's why point of care testing is not really something that you want to do in a chronic situation. The other problem is that the variation in your staff who's going to read it and the time it's read. If we bring the cup for various staff, each one of them can tell you whether a specific drug element in the urine, whether it's positive or negative, because there's a variation between the people who can read the color or who can read the numbers. So now you have not only created a controversy with the patient, you have created controversy within your staff. So who's going to say positive, who's going to say negative? And also the time is read. If it's read it immediately, if you keep it in the cup and you wait a little bit and you read it again, you will find also the different interpretation for the point of care testing. One thing that Michael touched too, that it does not give you specific semi-synthetic or synthetic drugs. So that's also you're missing a whole array of prescription medication that you would like to know about that is not included in the point of care testing. Does not show you the metabolite. We have also medication that have active metabolite, and we don't know if the patient is taking a drug that has active metabolite in the point of care testing. There's a long range of deficiencies in point of care testing. That would lead us that I don't see a role of point of care testing in a chronic treatment. It might have a role in emergencies.
Well, let me just get back to the point of care, because in certain settings, I can see emergency room settings where they have to make a clinical decision right there on the spot. In the primary care practice, we also have to make a decision because we're going to get a test and we're going to act on it, and we may act inappropriately if that test doesn't give us the right amount or right result. But there are certain things that we would expect to find. So if we find cocaine, for example, we find heroin in the urine, if those things are showing up, you probably could make a determination about that. If it requires a patient to pay money and we can do the point of care cheaply, that would have a value in certain populations if it's difficult for anybody to pay for that. Michael, do you have ideas about where it would be valuable in a primary care setting to use point of care?
Well, I think that you really have to understand the test and the limitations of it. I think that that's probably the most important factor. You can lull yourself into a false sense of security by certain test results. You can also inappropriately become angry and frustrated with your patient. And so I think that it's a blunt weapon. And it oftentimes leads to poor decision making. And so before you throw the patient out of the practice, before you, pardon me, assume that everything is going fine, you really have to know what that test is capable of doing or not doing for you in that given situation.
And it can be complicated.
Absolutely.
Especially in our setting where we have limited resources, limited lab techs that may not interpret it correctly, and we don't know what the meaning of it is frequently. So it is a hazard in a primary care. We should know how to use these.
The key, though, of point of care testing and its efficiency, you must identify the specific opioid or its specific metabolites in a pain practice in which you're prescribing opioid medications. And point of care is markedly deficient in doing that. It will readily pick up natural opioids such as morphine and codeine, but will not tell you which one is present.
What I hear from my colleagues about urine testing is that they can't get it approved, insurance doesn't cover it, so it's a cost issue frequently that comes up during the discussion about urine drug testing. How do you handle that, Howard?
Well, Bill, it's very hard to generalize about urine drug testing. Lab testing depends on the panel you're ordering, and simply put, it just varies across the country depending upon the vendor for point of care testing or the diagnostic lab that one uses. So you just maybe possibility call the lab, see what the cost is, and go from there. But I really can't say specifically what to do about costs.
Yeah, and I know there are indigent programs that many of the urine drug testing companies will give for those that really are underserved and can't afford to pay even a minimal amount, say $50 or $60, which to us doesn't seem like very much, but to a lot of patients it can be.
The point is you do what you can, and again, what you can do for the patient, and then you document it in a chart why you chose that particular way to do it.
Right, and the patient couldn't afford it. It's in the chart. I want to do urine drug testing. The patient couldn't afford it.
It
so
is
it's
what
there.
it is.
Yeah. So in summary, I want to point out that we have urine drug testing as the gold standard for monitoring our patients. And there's point of care, which is rapid, suitable in an emergency. I think it's suitable in some clinical practices in primary care because we are an emergency room oftentimes in my practice as well. There are plenty of problems with the point of care testing as far as length of time, the type of panel that you get, the metabolites, all of which has been discussed. And I'd like to thank our panel members for this valuable discussion.